Thank you, Beth. Thank you, Dr. Kinney and Dr. Sharma, for this wonderful opportunity to present, and it is truly my honor to be here. Again, my name is Hyojin Kang. I am the Structural Heart Program Manager here at Mount Sinai Hospital. And this afternoon, I will be giving you updates on transcatheter structural heart interventions. I have no relevant financial relationships. Prevalence of valvular heart disease increases with aging. As you can see in this graph, it really starts peaking for those who are in late 60s to early 70s. Treatment of valve disease is evolving with increasing patient age. We treat patients as young as in their 60s to as old as in their late 90s. Increasing patient complexity. Our patients don't just have high blood pressure, high cholesterol, and diabetes, but they have extensive medical history such as end-stage renal disease, multiple cancer history with radiation therapy in the past, which can all be challenging to be treated. And advanced medical therapy, which leads to better management of symptoms, improve surgical expertise. As our operators are becoming more proficient in their skill sets, our outcomes are better. Emerging medical invasive alternative with new development of medical innovations, our patients have more treatment options. So TAVR was initially introduced for those patients who were deemed as inoperable or too sick to have surgery. So in 2012, FDA approved TAVR for those high-risk patients. And in 2016, intermediate risk patients were approved. And finally, in August of 2019, low-risk patients were approved for TAVR. So TAVR is now indicated in all surgical risk categories. So now that TAVR is indicated in all across surgical risk categories, TAVR volume now exceeded SAVR volume. Surgery has been around for many years to treat aortic stenosis, but since the introduction of TAVR, it really has changed the paradigm of management of aortic stenosis. So remember how I just mentioned TAVR was offered for those patients who were too sick or who are not able to get surgery. Now surgery is offered for those patients who are not able to get TAVR. So why is TAVR preferred over SAVR? For obvious reasons, it's not open heart surgery. There's no incision, there's no bypass machine. Hospital stay is shorter. Usually our patients are being discharged within 24 to 48 hours. It's faster recovery. You're back to full activity level within 1 week. And studies have shown that there's no difference for SAVR at 5 years in high-risk patients, and there's no difference for SAVR at 5 years in intermediate-risk patients. And there's no difference for SAVR in 2 years in low-risk patients. However, there are pros and cons between the two. In SAVR, you have less PVL and less conduction issues, while TAVR has less AFib, bleeding, and acute renal injury. Hospital stay and recovery is shorter and faster with TAVR. Long-term durability is better with SAVR. And coronary access is harder with TAVR. Number of patients with coronary artery disease who are undergoing TAVR are surprisingly high. More than 60% of patients in our intermediate risk trials has CAD, and more than 20% of patients in low-risk trials had CAD. While in most of the times, angiogram and PCIs are successful after TAVR, it really depends on the operator experience and the device type. So the reasons for difficult coronary access after TAVR. Here, I get to use this clicker. Oops. Can this play? Sorry. Okay, so you have this leaky, bulky leaflet facing the left main, and with this TAVR sitting right outside, it is very difficult for coronary access. And here on your right, we have this TAVR valve inside the surgical valve, and with low left main and small STJ access, it is nearly impossible to engage the left main. So in terms of re-intervention after TAVR, there are a few key factors to consider. And first is TAVR durability. We don't know how long these TAVR valves last in our young patients. We are predicting anywhere from 8 to 10 years. So if you are getting TAVR in your late 60s to early 70s, then it is most likely you will need another intervention in your late 70s or 80s. Can TAVR in TAVR be done safely? There is high risk of coronary obstruction risk because of all these materials taking up the space. And hemodynamic is also important because the opening of the valve will be smaller given that there will be 2 TAVR valves inside the aortic root. And if you're not able to get TAVR in TAVR, then you have to undergo TAVR explant. And TAVR explant is more complex than first-time or redo SAVR. So here's an illustration that demonstrates the risk and the benefits of 3 potential strategies in lifetime management of severe aortic stenosis in our young patients. Here on your left, you have SAVR as your first intervention, followed by 2 TAVRs after. Benefit of this strategy is that you're having surgery at your young age, maybe in your 60s or early 70s. That way you won't have to have open heart surgery in your 80s. And valve-in-valve TAVR is well established. And here in the middle, we have TAVR as the first intervention at your young age, but you have to undergo TAVR explant and have surgical valve replaced. And then when the surgical valve fails, then you have to undergo TAVR again. And here on your right, we have TAVR, followed by TAVR, and followed by another TAVR. This, we still don't have enough data to support this strategy, not to mention not everyone has anatomy that is suitable to have 3 TAVRs in themselves. So I'm going to switch gear to mitral now. So mitral regurgitation occurs when the mitral valve fails to close completely, causing blood flow to move backward into the left atrium, which causes the leak in the valve. So MR is the most common valvular disease in the United States, yet it is largely undertreated. Here we have 4 million people living with at least moderate to severe MR, and of those, only 1.5% are being treated. Mitral regurgitation is progressively worsening disease, and if left untreated, MR can progress to heart failure and even death. And 1-year mortality is up to 57% left untreated, and not to mention multiple hospitalizations in between. So there are 2 types of MR. First is primary degenerative MR, which is the disease caused by the mitral leaflets. And secondary functional MR is disease caused by the left atrium and the left ventricle. This is the 2020 ACC guidelines to treat primary MR, which I will summarize in the next slide. And this is guideline to treat secondary MR. So how is mitral regurgitation treated? In secondary MR, first line of treatment has been the guideline-directed medical therapy. But this doesn't treat the disease itself, it treats the symptoms. So our secondary MR patients, despite of being on optimal GDMT, they may still experience heart failure symptoms. And conventional mitral valve surgery is still the gold standard treatment for primary MR, but it's not an option for everyone. So if you are deemed as high or prohibitive risk for surgery, then this is not an option for you. And surgery is rarely an option for secondary MR treatment. So for those who are left untreated, now we can offer TEER, which is transcatheter edge-to-edge repair using MitraClip therapy. And MitraClip therapy is currently the only FDA TEER device that's on the market. So MitraClip therapy, it's minimally invasive, it's safe, complications are very low, and it's a quick procedure. You're in and out of the procedure within 2 to 3 hours. and you're being discharged from the hospital within 1 to 2 days, just like TAVR. Lastly, tricuspid regurgitation. Tricuspid regurgitation occurs when the valve between the two right heart chambers, right ventricle and the right atrium, doesn't close properly. As a result, blood flows backward into the right atrium. So here on your left, you have the typical heart, and here on your right, you see that blood leaking back into the right atrium in the tricuspid regurgitation. So compared to other valve disease, TR is one of the most undertreated, and it is often known as the forgotten valve. There are about 1.6 million people living with at least moderate to severe MR, and of those, only 0.4% are being treated. So why is it so undertreated? Because the current treatment options are suboptimal. Medical therapy is limited. Again, this is symptomatic treatment. It doesn't treat the disease itself. Surgery is too high risk with poor outcomes. It has limited clinical evidence, and most TR surgeries are done in conjunction with other left-sided valve surgeries. It is associated with high mortality rate. Mortality rate is about 3 to 4 times higher compared to other open valve procedures. And transcatheter device can offer as an alternative. And currently, they're all under clinical trials, but some of them are very close to obtaining FDA approval. Again, it's minimally invasive, it's safe, complication rates are very low. And it is rapidly emerging and may ultimately become the preferred treatment option, just like what TAVR has done for aortic stenosis. So there are 2 tricuspid clinical trials that we are participating at Mount Sinai. There is tricuspid valve repair with TriClip device, and we have tricuspid valve replacement with Intrepid valve. So, in summary, TAVR is now indicated in all surgical risk categories in aortic stenosis. Lifetime management of patients with AS and CAD will be important when considering which valve to choose as the first intervention. High-risk anatomy of TAVR in low and intermediate risk patients should be considered SAVR as an alternative. And in primary MR, TR is indicated in high and prohibitive risk patients with suitable anatomy. And in secondary MR, TR is indicated after failing optimal GDMT. And tricuspid regurgitation is progressive condition with poor prognosis with limited treatment options. But the good news is that transcatheter tricuspid valve therapy is gaining momentum in clinical studies with promising outcomes. And that concludes my presentation, and here's my contact information. If you would like to help us with any referrals, that is where you need to contact me. Thank you so much for your time.